this module, I am going to discuss about an important topic of diarrhea in children. We all know that diarrhea is one of the important causes of under 5 mortality, and that is why this topic is of even more importance for discussion and more commonly asked in your entrance exams. So let us start the discussion. We will start with few definitions in diarrhea. What is called acute diarrhea? Here, the duration of diarrhea is less than 7 days and it is usually due to a infection. Okay, that is called as acute diarrhea. Okay, and the common type of diarrhea which we encounter in children. Next is called as a persistent diarrhea, which is a diarrhea that starts as an acute diarrhea but persists for more than 14 days. Okay, and this is also due to a infection. That is called persistent diarrhea. The last type of diarrhea is called as a chronic diarrhea, which are a rare group of diarrhea in children, and it is defined by diarrhea which is again more than 14 days of duration. However, it is a non-infectious condition. This diarrhea would be associated with conditions like malabsorption. So, going forward, I am going to discuss about acute diarrhea in detail and some important aspects of persistent diarrhea as well. Before starting the topic of acute diarrhea, you should know what is diarrhea. Diarrhea usually refers to loose stools. Or in other words, a child who is passing solid stools now starts to pass watery stools, then it is called as diarrhea. Or in other words, it is also called as change in the consistency of the stools. That is called as diarrhea. This definition is more important because there is another way also by which we can define diarrhea, like increase in frequency of stools to more than 3 episodes per day. Normally a child is passing 1 to 2 episodes per day, now passes more than 3 episodes per day, then also it can be defined as diarrhea. Now, if a question arises as to what is a better definition of diarrhea, always choose the first one. That is, change in the stool consistency is what is a better definition of diarrhea in children. Okay, right. So, moving forward with the discussion of acute diarrhea, as I have said before, acute diarrhea refers to a diarrhea of less than 7 days duration and usually it is due to an infection. And what is that commonest infection which causes diarrhea? It is viral infections only more commonly associated diarrhea when compared to bacteria. So let us start looking at the organisms causing diarrhea. Overall, most common cause is the virus, and in that virus it is rotavirus. That is a most common overall cause of diarrhea in children. Other viruses which can be associated with diarrhea in children include Norvac virus, adenovirus, astrovirus, and the calcivirus. These are the other viruses which can be associated with diarrhea in children. Now, talking about bacterial cause. If a question is about overall most common bacterial cause of diarrhea in children, then you have to answer E. coli. And what variety of E. coli? It is ETEC or enterotoxigenic E. coli. That is the most common type of E. coli associated with diarrhea in children. There are also other bacterial causes of diarrhea which includes Salmonella, Shigella and Campylobacter. Okay, right. The last group of organisms associated with the diarrhea include parasites. Here is an important question that parasites normally are not encountered as a cause of diarrhea in pediatric population. However, in children with immunodeficiency, they are commonly associated. So immunodeficiency is one of the predisposing factors for a child to develop diarrhea associated with parasites. And what are the common parasites included in this group? Most common parasite is the Giardia. Others include entamoeba, that is Entamoeba histolytica, and also Cryptosporidium. Now this Cryptosporidium especially is an important organism to remember, because Cryptosporidium is the most common parasitic cause of diarrhea in HIV infected children. So in patients who are HIV positive, Cryptosporidium is a common cause of diarrhea. So as you can see that from this one particular cause of diarrhea itself, so many MCQ questions are possible. So please make a note of them and keep revising them. Next, you should know about a condition called as dysentery. Dysentery is a condition characterized by presence of loose stools. Along with that, there is also blood in the stools. That is when you call it as a dysentery. Why you should know about this term? Because dysentery is almost always bacterial in origin. Okay, and there is a question that most common bacteria associated with dysentery in children. What is that? Yes, it is Shigella. And the common type of Shigella which is associated with dysentery is Shigella flexneri. This is an important question. Okay, Shigella flexneri is the commonest cause of dysentery in children. So remember this as a practical point. You encounter a child with diarrhea, the most common cause is rotavirus, for which you don't need to start an antibiotic. However, if you encounter a child with dysentery, it is almost always due to bacteria. So in your prescription, you should always add an antibiotic. This is the general point which all of you should remember. Now, moving forward, we will discuss about a typical case of diarrhea, and that is rotavirus diarrhea. As I said before, there is no need for starting any antibiotic. However, the cause of concern in a child with rotavirus diarrhea is about dehydration. Yes, because the child is passing loose stools, child can develop dehydration. So first thing in management of diarrhea is to assess if the child has dehydration or not. Okay, and according to presence or absence of dehydration and severity of dehydration, there are three types. One is no dehydration. Second is some dehydration. Where child is losing around 50 to 100 ml per kg of fluid. So 50 to 100 ml per kg of fluid loss is there. And the last one is severe dehydration. Which is characterized by a fluid loss of more than 100 ml per kg. Okay? Yes. These are the three basic terminologies associated with dehydration and diarrhea. Now we have to know what are the features of dehydration. Remember, I am going to strictly discuss this from the exam point of view. I am not going to list down all the 10 features and say that this is no dehydration, some dehydration and severe dehydration. It is not at all helpful. I am going to tell you in a very practical way, as well as the way which you should remember while answering MCQs in this topic. You look at a child with diarrhea. If a child appears to be very active and alert, then it is no dehydration. Very simple and straightforward. Okay. Next thing is, in some dehydration, child will be thirsty, and at this stage child will be slightly irritable. Okay. Whereas in severe dehydration, child is lethargic, not active at all. That is a characteristic feature of severe dehydration. And in all children with diarrhea and suspected dehydration, we do a test called skin pinch test. What we do, we pinch the skin over the abdomen and look for the response time. Okay, this is what is called as a testing for skin turgor. Okay, right. Remember, in case of no dehydration, the skin response time is very quick. What is the meaning of very quick or fast? The response time is less than 1 second. Whereas in some dehydration, it would be slow. Slow is defined by a response time of less than 2 seconds. And in severe dehydration, the response is very slow. Very slow is defined by a response time of more than 2 seconds. This is an important part of assessment in dehydration, and whenever a clinical scenario question is going to be asked, they stress on this point. So you should know this very thoroughly. Having known about the features of different types of dehydration, you should know about the plan of management for each type of dehydration. For no dehydration, it is called as Plan A management. For some dehydration, it is Plan B management. And for severe dehydration, it is Plan C management. I am going to explain each of them in detail. Starting with Plan A management, which is for no dehydration. Here, what we need to do is replace whatever fluid child has lost in the form of loose stools. This is called as replacement of ongoing loss. Okay? And this replacement of ongoing loss is typically by giving ORS. How much ORS to be given? It depends on the age of the child. If a child is less than 6 months old, usually we give 50 ml of ORS for every loose stools. Okay? It is simply calculated as 1/4 of a glass. Okay? That is 50 ml, which is recommended for a child less than 6 months. If the child is between 6 months to 2 years, roughly 50 to 100 ml of ORS for every loose stool is recommended. That means 1/4 to half of glass of ORS is recommended for every loose stool. And if the child is more than 2 years, you have to give 200 ml of ORS for every loose stools. So roughly 1 glass of ORS for every loose stools. That is the approximate calculation in Plan A management for dehydration. Okay, and don't forget the term. It is called replacement of ongoing losses. Okay, next moving on to Plan B management, which is for some dehydration. Remember here, the first step is correction of dehydration by rehydration. Okay, and here again the fluid which is used is ORS, oral rehydration solution. How much ORS to be given during rehydration? You have to give it 75 ml per kg over 4 hours. Okay, very important. The initial step is rehydration. The second step is to replace ongoing loss. Okay, just like what I said in Plan A, you have to give ORS as and when the child passes stool, and the amount of ORS is calculated according to the age of the child. Okay, right. And third part of management is something called as giving maintenance fluid or giving the daily fluid requirements. Okay. And how much of maintenance fluid to be given, or what is the normal daily requirement? It is calculated by a formula called as Holiday-Segar formula. Okay. Yes. Holiday-Segar formula is again calculated according to the weight of the child. Okay. If the weight is in the range of 0 to 10 kg, you have to give 100 ml per kg. Remember, we are talking about daily fluid requirement. So, whatever fluid I am going to calculate from this formula is for 24 hours or a daily usage, not hourly usage. That is the point to be noted. Next is a child between 10 to 20 kilograms. Here, we calculate like this: 1000 ml plus 50 ml per kg for every kg above 10 kg. That is for a weight between 10 to 20 kilograms. If the weight is more than 20 kilograms, we'll calculate as 1500 ml plus 20 ml per kg for every kg above 20 kg. I'll take this as an example. For example, the child is weighing 22 kilograms. How much fluid you are going to give? You will straight away start with 1500, okay? And then you have to add 20 ml per kg for every kg above 20 kg. How much kg here is above 20 kg? It is 2 kg. So 2 into 20, which is 40 ml. So total requirement would be 1540 ml per day. That is a daily fluid requirement for a child weighing 22 kg. Hope you are able to follow this. Don't forget this important formula called Holiday-Segar formula. Okay. So always remember this, that whenever you have a child with dehydration, first correct the dehydration, replace the ongoing loss, and third, you have to give maintenance or daily fluid requirements. Okay, right. That is about plan B. For plan C, again, the same principles will apply. What is that? You have to give rehydration. You have to give replacement of ongoing loss. You also have to give daily fluid requirements. Okay. However, there is some difference in plan C with regards to rehydration. What is that? Remember, in plan C, the child is lethargic, correct? So we cannot give a oral fluid. Here you are supposed to be using intravenous fluids. And for IV fluid administration, RL or ringer lactate is preferred in comparison to normal saline. So RL is the preferred fluid for fluid treatment in case of severe dehydration associated with diarrhea. Second important thing is the amount of fluid to be given for rehydration is 100 ml per kg. Please remember this. For some dehydration, I was telling you the amount of fluid for rehydration is 75 ml per kg, but here it is 100 ml per kg. How are you going to give this 100 ml per kg? Let's see. 100 ml per kg of fluid is divided as initial 30 ml per kg, later 70 ml per kg. Okay. Within how much time you have to give it? Again decided by the age of the child. If the child is less than 1 year old, you give that 30 ml per kg over 1 hour. And 70 ml per kg, you give it over 5 hours. So the total duration over which you give that 100 ml per kg is 6 hours. Okay, right. Whereas if the child is more than 1 year, you can give it at a faster rate. For example, 30 ml per kg can be given over half an hour and 70 ml per kg can be given over 2.5 hours. So here the total duration becomes half of 6 hours, which is 3 hours. This is the change which you should clearly note while treating a child with severe dehydration. So this table summarizes the fluid management or correction of dehydration in a child with diarrhea. So when we talk about management or treatment of diarrhea, fluids are the cornerstone of treatment. The fluid is commonly oral rehydration solution, and if the child is not able to take orally, you have to give IV fluids. Okay, just a note about this oral rehydration solution. What we are using at present is WHO recommended low osmolarity ORS. Okay, and the total osmolarity of this ORS is 245 milliosmoles per liter. And at this time, it is very, very important that you should know the breakup of this 245 milliosmoles. Basically, ORS is composed of electrolytes, okay, so and nutrients like glucose. So you have to know what is the composition of that electrolyte and glucose in ORS. Very simple. Sodium is 75. Glucose is also 75. Why is sodium and glucose kept in the same concentration? Because we all know that in the intestine there is something called SGLT1, which is S for sodium, GL for glucose, T for transport. It's a sodium glucose co-transporter which transports one molecule of sodium along with one molecule of glucose. That is why sodium and glucose is always kept in the ratio of 75-75 or 1:1 ratio. Okay, right. The other constituents include potassium, which is kept at level of 20, chloride is 65, and citrate is 10. If you total everything, it makes up to 245 milliosmoles, and that is what is the total osmolarity of this WHO ORS. Okay, right. So ORS composition is very important and frequently asked in the exam that you should be knowing about. In addition to fluid, anything else is recommended in the management of diarrhea? It is zinc. Please remember the role of zinc. Zinc helps in the epithelialization of gastrointestinal tract. That is why you are using in a case of diarrhea. It also decreases the severity of the loose stools as well as decreases the future recurrence of diarrhea in a child. That is why it is very, very important you give zinc in a child with diarrhea. You should know about the dose as well as the duration of zinc treatment. Dose is dependent on the age of the child. If the child is less than 6 months old, you give 10 milligram per day of zinc. And if the child is more than 6 months old, you give 20 milligram per day of zinc. Okay, the duration of zinc treatment is 14 days. Irrespective of the age, you give it for full 14 days. So in addition to the fluids, zinc is recommended in the management. You should also know that at present, there is no role of the following medications. Okay, there is no role of anti-motility agents like loperamide, there is no role or no recommendation for anti-secretory agents like resigadrotril. Okay, and there is also no recommendation or no guidelines for recommendations of probiotics at present. So in most case of diarrhea, you will use only fluids and zinc. That's all. At this time, you should also know that there are some specific indications for antimicrobial treatment. There are 4 important indications. Number 1 is in a child with dysentery. I told you in the beginning of this module itself, dysentery is almost always caused by bacteria, so you should use antibiotics in the management. And what is a commonly used antibiotic? It is 3rd generation cephalosporin like cefixime. Other medications which can be useful in the management are ciprofloxacin and azithromycin. However, the commonly used agent is the 3rd generation cephalosporin like cefixime. That is important. Second, in a child with a severe malnutrition, always remember bacterial infections are highly likely. So there also you have to start an antibiotic. The usual combination of antibiotics started is ampicillin with gentamicin. Okay. The third important indication for antibiotic is in a child with established diagnosis of cholera. And in cholera, most of you should be knowing what is the drug of choice. What it is? Yes, it is doxycycline. And finally, if there is a proven case of giardiasis or amoebiasis, what drug can help in the management? It is metronidazole. These are the indications for antimicrobial usage in a case of diarrhea. So to sum up, acute diarrhea is usually a viral mediated disease and the most common virus is rotavirus. Always in a child with diarrhea, please assess the dehydration status and treat accordingly. No dehydration simply requires only replacement of ongoing loss in the form of ORS, whereas dehydration requires upfront correction of dehydration with 75 ml per kg of fluid in case of some dehydration and 100 ml per kg of fluid in case of severe dehydration. Please remember, only in severe dehydration IV fluids are used, whereas in other cases it is ORS which is useful. In addition to ORS, zinc is mandatory in the treatment for all cases of diarrhea. Antibiotics are only used in the exceptional situation as I have discussed, which includes cases of dysentery, cases of cholera, children with severe malnutrition, and in confirmed cases of amoebiasis and giardiasis. That is about the discussion of acute diarrhea in children. Next is about persistent diarrhea in children. What is the definition of persistent diarrhea? I told you, diarrhea lasting for more than 14 days and due to an infection, you call it as persistent diarrhea. It is simply that the diarrhea starts as an acute diarrhea only, but it persists for more than 14 days. So why do you think some children alone, the acute diarrhea is going in for persistent diarrhea? It is because they have some risk factors for development of persistent diarrhea. Okay. Some of the important risk factors include age of the child. Very important. Age less than 1 year. Okay, and commonly it is in the age group of 6 months to 1 year. This may probably be related to immaturity of the gastrointestinal tract as well as the immune system to overcome the infection. So that is why the infection is persisting for a long period of time. Number 1. Second is children who are born as low birth weight babies or babies who are born as small for gestational age or SGA babies, as well as children with malnutrition. What happens here is there is a delay mucosal healing, okay, or delayed healing of the gastrointestinal mucosa. This results in unusually prolonged diarrhea causing persistent diarrhea. That is the second reason. Third is some organisms itself can be associated with persistent diarrhea. These include varieties of E. coli like enteroadherent E. coli and enteroaggregatory E. coli. They can be associated with persistent diarrhea. Other group of organism includes Salmonella as well as Shigella. They can be associated with persistent diarrhea. Fourth important group is lactose intolerance. Okay. I will shortly discuss this condition. At that time, I'll be telling you that lactose intolerance is both a risk factor as well as a consequence of persistent diarrhea. I'll keep that discussion to the later part. As of now, we will continue discussing the other risk factors. The last important risk factor is an important condition called as CMPA. What is that? It stands for cow milk protein allergy. Okay. As you can infer from the name, it is due to allergy caused by the cow milk proteins. The common proteins which are implicated in this condition include beta lactoglobulins as well as the casein. Okay, so the child who is having allergy to these proteins can develop cow milk protein allergy, and that results in unusually prolonged or persistent diarrhea. These are the important risk factors for the development of persistent diarrhea in children. Let us look at the consequences of persistent diarrhea. It can predispose to nutritional deficiency, especially deficiency of micronutrients. And one of the most important micronutrient deficiency encountered in children with persistent diarrhea is vitamin A deficiency. That is why it is always important that when you are treating these children with persistent diarrhea, you have to give 1 dose of vitamin A. That is one thing. Second important consequence which can develop is lactose intolerance. Let us see in detail about how lactose intolerance develop, as well as some of the features of lactose intolerance in persistent diarrhea. Okay, imagine like this. This is the gastrointestinal tract. We know that when lactose is going to come into the gastrointestinal tract via the milk, it is going to be digested with the help of the digestive enzyme lactase. And where is that lactase enzyme present? It is present in the villi like this. Okay, especially this lactase enzyme is present in the tip of the villi. Okay, right. This is a location of the lactase enzyme which is in the tip of the villi. Now what happens in cases of persistent diarrhea? There is loss of the tip of villi. Okay, whenever the tip of villi is getting lost, there is also loss of lactase activity. Okay, so very simple. What is going to happen in persistent diarrhea? There is no digestion of the lactose, right? So the lactose will pass down the gastrointestinal tract in the undigested form like this. And once it enters into the colon, in the colon there are colonic bacteria which will convert this undigested lactose into two important substances. One is lactic acid and the other one is hydrogen. Okay, this lactic acid can be excreted in the stools, resulting in perianal rash, or it is also called as perianal excoriation. Okay, hydrogen is a gaseous substance which when excreted in the stools results in a explosive stools or gaseous stools. Okay, so these are the usual features of lactose intolerance, which includes perianal excoriations as well as gaseous or explosive stools. Okay, and this is a condition which occurs as a consequence of persistent diarrhea. We call it as lactose intolerance. Because this condition is due to persistent diarrhea, we call it as a acquired lactose intolerance, or also called as secondary lactose intolerance. Okay, these are the two main consequences of persistent diarrhea that one should know about. Now coming to the management of persistent diarrhea, again you have to give them ORS according to the level of dehydration. Like what I said for acute diarrhea, you assess dehydration and treat with fluids. You also have to give zinc, same dose and same duration like what we discussed in acute diarrhea. Third important thing is you have to give vitamin A supplementation. Okay, you have to give a single dose of vitamin A. Okay, that dose is determined by the age of the child. In a child less than 6 months, you give 50,000 international units of vitamin A. 6 to 12 months, you give 1 lakh international unit of vitamin A, and after 12 months, you give 2 lakhs international unit. This is recommended because I have told very clearly that one of the consequences of persistent diarrhea is vitamin A deficiency. Okay, right. Final point in the management of diarrhea is because of lactose intolerance, you have to decrease or in some cases completely avoid lactose in the diet. Okay, and this management is usually done in 3 stages. First, we will start with the diet A, which is a diet which is having low levels of lactose. How? It is nothing but diluting the amount of milk given in the diet or decreasing the amount of milk which is given in the diet. It is usually given by mixing the rice with the milk and forming a gruel, rice milk gruel, or you can make a gruel of suji and milk, or you can mix rice with a curd. All these are ways by which we can decrease the amount of lactose in the diet. Suppose child is not responding to this diet A, which is low lactose diet, then you have to go for diet B. Diet B is a no lactose diet. That means you completely avoid lactose in the diet, or in other words, you completely avoid milk or the dairy products. That is the point. Okay, and here you will also give a diet which has got reduced amount of starch. Okay, right. The typical examples are you give cereals, glucose as carbohydrate intake, and for protein you can give egg or chicken protein recipes. Okay, that is what you give as a source of protein in these children. That is the diet B, which has to be started in case children are not responding to diet A. Third is diet C, which obviously will be started when there is no response to diet B. Here, no lactose as well as no starch in the diet. Okay, no lactose as well as no starch in the diet. So it is basically a monosaccharide based diet. It's a monosaccharide based diet where you will give plain glucose to the patient as a source of carbohydrate. Plain glucose to the patient, okay, which is a monosaccharide. And for protein, you can give egg white or chicken purees. That is what is recommended in this dietary plan of monosaccharide based diet. So these are the dietary plans which you have to adapt in a child with persistent diarrhea and having problems of lactose intolerance. So that is about the discussion of persistent diarrhea, and with that I end the module on diarrhea in children.